Welcome all. This presentation is being done as a part of the pre-workshop learning for the upcoming Dialysis Technology Update 2024 being organized by the Department of Nephrology, All India Institute of Medical Sciences, Nagpur, in association with the Nephrology Society, Nagpur. I am Dr. Anand Chellappan. I will be giving an overview of Continuous Renal Replacement Therapy. We will be covering some of the basic concepts of CRRT in this presentation. These are the learning objectives of this presentation. The term CRRT stands for Continuous Renal Replacement Therapy. CRRT is the abbreviation of Continuous Renal Replacement Therapy. CRRT is a form of extracorporeal renal replacement therapy. Now coming to the indications for performing continuous renal replacement therapy. If a patient is not responding to medical management and has any of the following indications for dialysis, then such a patient has an indication for CRRT like hyperkalemia or metabolic acidosis or symptoms or complications of uremia or fluid overload or pulmonary edema. Now, the decision to start CRRT is not based on an isolated value of urea, creatinine or electrolytes potassium, but it is instead based on the condition of the patient, who can be an adult, child or even a young person as a whole. What are the various modalities of extracorporeal renal replacement therapy that we have? We can classify these modalities of renal replacement therapy that we perform in the dialysis units and in our critical care units. We can classify them according to the session frequency and duration into intermittent therapies, hybrid therapy and continuous therapy. Now, the intermittent therapy are therapies which are usually 3 to 5 hours in duration. These are the hemodialysis sessions which we perform in our maintenance hemodialysis patients. It also includes hemodiafiltration and even high flux dialysis. Now, hybrid therapies fall in between intermittent therapy and continuous therapies. These include SLED, slow low efficiency dialysis, and SLED-F, slow low efficiency diafiltration. And these therapies typically continue for 8 to 12 hours. Finally, we have the continuous therapies, which are CVVHT, that is continuous veno-venous hemodialysis, continuous veno-venous hemofiltration, continuous veno-venous hemodiafiltration. These therapies are continuous as per their name, and the durations typically range from 24 to 48 or even 72 hours depending upon the filter life. Now, what are the advantages of CRRT? CRRT is suitable for hemodynamically unstable patients. For example, patients in the critical care units, in the ICUs, whose blood pressures are lower and inotropes, vasopressors are being used to maintain the blood pressure. These patients may benefit from CRRT, and in these patients performing dialysis, hemodialysis, intermittent hemodialysis, which we are mentioning here, is difficult. Now, fluid removal is continuous, making it comfortable to regulate volume. That is another advantage of CRRT. CRRT does not induce an increase in intracranial pressures. So it is useful in patients who have neurological insults. It is easy to use in the ICU since it can be performed bedside, whereas intermittent hemodialysis, slow low efficiency dialysis require separate infrastructure, RO water, and may not be possible to perform bedside always. Another advantage of CRRT when we compare it with hemodialysis or SLED is there is a better clearance of middle molecules and immunomodulatory substances in addition to small solutes. Now let us compare the three modalities: intermittent hemodialysis, slow low efficiency dialysis, and CRRT. The typical blood flows in intermittent hemodialysis is 250 to 400 ml per minute, whereas in SLED it is usually 100 to 200 ml per minute, and in CRRT also it is usually 100 to 300 ml per minute. Coming to the dialysate flows, intermittent hemodialysis has the highest dialysate flow ranging from 500 to 800 ml per minute. This is followed by SLED, which is typically 300 ml per minute. And in CRRT, it is much lesser, it is 17 to 34 ml per minute. A typical intermittent hemodialysis session lasts for 3 to 5 hours, SLED 8 to 12 hours, and CRRT is a continuous form of therapy. Now, what are the advantages of intermittent hemodialysis? It can remove a large amount of fluid in the short duration. It can correct solute disturbances and remove the solutes quickly. And severe hyperkalemia patients benefit better with intermittent modalities since the removal is also fast and enhanced. These are the advantages of intermittent hemodialysis over SLED and CRRT. Whereas SLED and CRRT are better tolerated in patients with hemodynamic instability and they offer a better fluid control. So that is where is the advantage of SLED and CRRT over intermittent hemodialysis. What are the prerequisites for CRRT? The most important and the first most important prerequisite is the vascular access. A temporary or a permanent hemodialysis catheter is the preferred vascular access. Fistulas, AV fistulas and AV grafts are not typically used because of fear of access complications when we use them for CRRT. Now these catheters are inserted into veins like the internal jugular vein, femoral vein or the subclavian vein. An internal jugular vein approach is the most preferred approach. Since the catheter is inserted into a vein, the blood is taken out from the vein and the purified blood after it passes through the CRRT is again let into the vein. So it is a continuous veno-venous circulation. The next important component is the CRRT machine. The machine displayed in this picture is a Baxter Prismaflex CRRT machine. There are multiple brands of CRRT machines. Then we need the consumables of CRRT, which includes the CRRT kits, which have the various parts of the circuit, and some kits also contain the CRRT dialyzer and the CRRT fluids. In a typical hemodialysis or slow low efficiency dialysis, an RO water plant is required, the RO water supply is required to generate dialysate, whereas in CRRT, dialysate replacement fluids are used in the machine and it can be performed bedside, making it useful for critically ill patients. What are these CRRT solutions? These solutions are similar in composition to the plasma. They generally contain a mixture of electrolytes like sodium, potassium, calcium, chloride and magnesium. A buffer like lactate and or bicarbonate and glucose. There are various brands of CRRT solutions, but in general they contain a mixture of electrolytes, buffer and glucose. An important point is that the lactate buffer in CRRT solution is now largely being replaced by bicarbonate buffer. And another important point is we should avoid calcium containing solutions when we are performing regional citrate anticoagulation. So the image shows some of the available CRRT solutions. There are multiple brands of CRRT solutions. The listeners are advised to review the composition of the CRRT solutions, and more regarding these solutions would be discussed in the upcoming workshop. Some of the solutions contain phosphate, and as we had previously discussed, the buffers differ between the solutions, and which solution to be used in which condition would also be discussed in the workshop. Let us now understand the CRRT dialyzers. This is a CRRT kit, and this part is a CRRT dialyzer. Some brand CRRT kits contain the CRRT dialyzer along with the kit. In some brands, the dialyzer is separate from the kit. Now this is the CRRT dialyzer. This is a schematic diagram of the CRRT dialyzer. So the blood goes into the CRRT dialyzer and there comes out, and the dialysate flows in the opposite direction and comes out. This is a typical movement of blood and dialysate across the filter. Now, these filters are all hollow fibers, hollow fiber dialyzers. Let us now see how the dialyzer is structured. Let's take a cross section of this hollow fiber. So on one side of the fiber we have the dialysate, and on the other side of the semi-permeable membrane we have blood. So these fibers are made up of a semi-permeable membrane. On one side is blood and on the other side is the dialysate. So across the fibers the blood runs, and on the other side of the semi-permeable membrane is the dialysate. Now these are hollow fibers like we had already discussed, and they have a large surface area, making it a high efficiency dialyzer, and the pores that we see are also large pores, making it a high flux. So the CRRT dialyzers in general are high efficiency and high flux. Now let us try to understand how this dialyzer helps in dialysis. To understand that, we need to know the solutes and the toxins which accumulate in the blood of the patient with renal dysfunction. These can be small solutes, or they can be middle molecules, and they can also be large molecules. So these are all found in a patient who has a renal dysfunction, and our goal is to remove these solutes during the procedure of CRRT. Now, how do we do that? Let us go step by step and see the different processes which operate in the CRRT dialyzer and help in dialysis, which is happening in CRRT. Now these are the small molecules, the yellow spheres in this schematic diagram. Now diffusion is a movement of solute from a place of higher concentration, which in this case is blood, to a place of lower concentration, which is the dialysate, across the semi-permeable membrane. This process is called diffusion. Now the middle molecules are not removed to a larger extent by diffusion. So how should we get rid of them? One another way to get rid of the middle molecules is called Convection. In convection, we add a replacement fluid to the blood compartment, and this replacement fluid drags along with it the middle molecules from the blood compartment to the opposite compartment across the semi-permeable membrane. This process is called convection or solvent drag, where the solvent is the replacement solution we have given. It drags along with it the middle molecules across the pores in the dialyzer. So these are the two main mechanisms which are operative in the CRRT dialyzers, and there are different dialyzers which can perform these modalities. The other mechanism of removal of toxins is adsorption. Adsorption means adherence to the surface, the semi-permeable membrane. For example, larger molecules like albumin can get adhered to the pores. One another problem which is associated with this is the clogging or the blocking of the pores of the dialyzer over time when we use it continuously in CRRT. Now, what are the different types of CRRT? We saw the terms CVVHD, CVVHF, CVVHDF. So let us try to understand the mechanisms of dialysis operating in each of these modalities and the corresponding terms. Now, diffusion, where there is movement of solute across a semi-permeable membrane from a region of higher concentration to a region of lower concentration, it is called diffusion. And the modality which predominantly uses diffusion is hemodialysis. The same when we perform it in the CRRT machine with a slow blood flow rate and dialysate flow rate, it is called continuous veno-venous hemodialysis. When convection is the predominant mode of dialysis in CRRT, it is called continuous veno-venous hemofiltration, where there will also be some diffusive removal of small solutes and there will be removal of middle molecules as well, as we previously saw in the mechanisms. When a combination of both is operative, that is, there is both dialysis as well as diffusion as well as convection happening, then it is called CVVHDF, that is continuous veno-venous hemodiafiltration. Now this is the basis of these terms CVVHD, CVVHF, CVVHDF. I hope all of you can understand the mechanisms of dialysis operative in each of these types of CRRT. The other modality of CRRT, where there is actually no dialysate, but we are just trying to remove the fluid from the blood compartment with the use of pressure, it is called slow continuous ultrafiltration, SCUF. It is used in patients who have refractory volume overload. Despite using diuretics, it can help to decongest these patients. Since it's a slow form of therapy, the fluid removal is also slow and it can be controlled, and it gives a better volume control. Summarizing, the four types of CRRT are CVVHD, where the predominant mechanism is diffusion, CVVHF, where the predominant mechanism is convection, and CVVHDF, where the predominant mechanisms are diffusion as well as convection. In SCUF, there is just slow ultrafiltration. Now let us examine the parts of a CRRT machine. On this side we have the Baxter's Prismaflex machine. On this side we have the Fresenius multifiltrate machine. Broadly, all the CRRT machines have certain parts which we will try to cover in this segment. The listeners are directed to the individual manufacturer catalogs for more details regarding these machines. We have alarm lights and sound indicators on top. the colors of which indicate certain type of alarms. Then we have the interactive patient therapy screen, where the patient therapy monitoring can be done and various parameters can be set and also followed up. It's an interactive screen. Then we have the filter holder. So the filter comes as a kit which is attached to it with a barcode sensor, and it attaches to the holder. This is the Fresenius Multifiltrate Pro machine, and it has a separate holder for the dialyzer, and the filter is hung over this surface. So these are the fluid scales. This is on top of the machine in the Fresenius Multifiltrate Pro, and it is on the lower part of the machine in a Baxter CRRT machine, that is the Prismaflex or the Prismax machine. Now, these are gravimetric scales. So these are typically 5-liter solution bags. So based on the utilization and the weight, the amount of fluid used is calculated by the machine. So these are very sensitive scales. So if there is any disturbance adjacent to these scales or the movement of these fluids, it can interfere with the machine's interpretation of the fluid usage, and it can also give alarms. Now on this side we have the effluent scale. That is, once the dialysate is used up, it gets collected in the effluent bag. So it is hung here in this machine, and it is usually hung here in this Fresenius Multifiltrate Pro machine. These are 5 to 10 liter bags. Now let us examine the pumps in the CRRT machines. Different CRRT machines have different number of pumps. To achieve the purpose and to give the various forms of therapy, that is CVVHD, CVVHF, CVVHDF and SCUF. So let us just check the basic pumps. So this is the blood pump. In this picture, with the pre-connected circuit, you can see the blood coming in and it's being pumped into the dialyzer. And here in the Fresenius machine, we have the blood pump here. Then we have the dialysate pump, which is located here in the Fresenius machine. It is located here in the Baxter Prismaflex machine. Then we have the effluent pump. So the blood goes this way, and the effluent, the dialysate comes this way, and the effluent gets collected in this line, and it passes through this route, and it goes through the effluent pump and finally into the effluent bag. Similarly, in this machine, the effluent pump is located here, and it passes through this line. Then we have the replacement fluids. Now, replacement fluids are used in convective therapies, hemofiltration, CVV hemofiltration and CVV hemodiafiltration. So they can be given either before the filter or they can be given after the filter. So you have to have pumps to give it either pre or post blood pump. So in the Baxter machine, we have the pre-blood pump replacement pump. This is the post-blood pump replacement pump. And this is the replacement pump in the Fresenius machine, and this can be connected pre or post. So a total of 5 to 6 pumps are existent in most of the machines. There are 2 more pumps here. The purposes of these we shall subsequently discuss. Now, one of the integral part of a CRRT machine is its safety mechanism. The multiple pressure sensors in the CRRT machine, which help us to sense the pressures in various parts of the circuit and can give safety alarms to the therapy performing personnel. So let us start with the blood pump. This is the blood pump, and this segment prior to the blood pump is the inflow segment, where we take the blood out of the patient into, and it's taken into the CRRT system, extracorporeal system. So in this machine, it is the blood enters this way. So there is a sensor which is in the blood circuit before the pump. This is the inflow pressure sensor. So from the vascular axis, that is the catheter, we have the inflow segment, and it has the inflow pressure sensor. So this can help us to give an idea about access related issues. So any abnormalities in the pressures can give alarms. So this can give rise to access alarms. And this is the pressure pod before the blood pump. It's an inflow pressure sensor. Then we have the filter. So this is the CRRT filter. This is the blood pump. This is the inflow pressure sensor. So after the blood pump, it goes through the pre-filter pressure sensor and then into the filter. So any abnormalities in the filter, like a clotting of the filter, will be reflected by this pressure sensor by an elevating pressure. Similarly, it is located here in the Fresenius machine, after which it goes into the dialyzer, which is attached to this holder. Now, once the blood passes through the dialyzer, it comes out through this line. This is the outflow line. It passes through the venous drip chamber, and here we have the outflow pressure sensor. So this can sense the pressure abnormalities in the outflow segment. And this outflow pressure sensor is located here in the multifiltrate machine. Now we all know that the outflow line, even in a typical hemodialysis, has the drip chamber. So the drip chamber of the CRRT machine is located here, and it is located here in a Fresenius multifiltrate Pro machine. After the bubble trap, we usually have the air bubble detector. Even in a normal hemodialysis machine, we have this. Same, we have it in a CRRT machine, which can detect air bubbles. It is unsafe to let air bubbles go into the patient circulation. So if this optical sensor detects air bubble, then it will clamp the circuit. So we have a clamp which is present downstream in the circuit, a line occlusion clamp. So this slide shows us the various parts of the CRRT circuits and the various pressure sensors, safety mechanisms. And whenever an air bubble is detected, these machines are knowledgeable and intelligent to give us alarms and warn the technician and also the treating physicians regarding the issue. Now, this was in the blood circuit. There's also the effluent circuit. The effluent passes from this side and it comes out this way. It passes through a pressure sensor called the effluent pressure sensor, and then there is also the blood leak detector, and then through the effluent pump into the effluent scale. So this effluent sensor is located here, and this is the effluent pump of the Fresenius machine. So the effluent passes through this way, and this is the blood leak detector. Blood leak means there is a leak from the blood compartment into the dialysate compartment. That is why the effluent will start containing blood. So when it contains blood, the detector detects it and gives a warning alarm. Now let us examine the parts of a CRRT circuit with the help of a schematic diagram. In this diagram, we have the patient here. As we discussed in the preceding sections, a temporary or a permanent hemodialysis catheter is a preferred vascular access. So the blood is drawn from the patient through the vascular access, which is placed in a large vein, and this passes through this segment to lead into the CRRT dialyzer or the CRRT filter. And this part of the circuit contains the inflow pressure sensor, the roller blood pump, and the pre-filter pressure sensor. These pressure sensors play an important role in identifying changes in pressure in various parts of the circuit, and they give rise to safety alarms. The inflow pressure sensor gives us an idea about the access and also this part of the circuit. And the pre-filter pressure sensor gives us an idea about the filter or the CRRT dialyzer. The blood then goes into the CRRT dialyzer and finally it's returned to the patient. In the return line, we have the venous drip chamber and also the outflow pressure sensor. Now, the outflow pressure sensor gives us an idea about the pressures in the return line and can give rise to safety alarms when these pressures exceed the limits or are beyond the limits. Now, this is the blood circuit in the CRRT. Now, we have the dialysate as well. Now, before going into the dialysate circuit, let us see the anticoagulation, which is heparin, which is given here, and the heparin is given pre-filter. The point to be noted is it is given pre-filter so that it can prevent the clotting in the CRRT dialyzer. Now, dialysate goes into the filter and it comes out as effluent, and there is also a pressure sensor in the effluent line. As we previously discussed, this line also has a blood leak detector which can give off the blood leak alarm. Now, this is the circuit of CVVHD, that is continuous veno-venous hemodialysis, in which we have only dialysate, there is no replacement fluid. So, the predominant mode of dialysis is diffusion, which is operative in CVVHD. We can use either heparin anticoagulation or we can use regional citrate anticoagulation in CVVHD or CVVHF or HDF. We will be discussing about anticoagulation in the subsequent slides. Now, if you want to use convective therapy also, then we need to use replacement solutions. Now, these solutions will drag those middle molecules across the semi-permeable membrane into the effluent, giving rise to the convective component. So, they can be given either before the filter or they can be given after the filter. They can be given pre-filter or post-filter. So, when we use convection along with diffusion, then it is called CVVHDF. If we just use convection but there is no dialysate, then it is CVVHF. So, these are the different parts of the circuits in CVVHD, CVVHF and CVVHDF. Going further, anticoagulation in CRRT. The common anticoagulants used are unfractionated heparin or it is regional citrate anticoagulation. There are other methods of anticoagulation which are uncommonly used, like low molecular weight heparin, etc. Let us review unfractionated heparin as an anticoagulation strategy in CRRT. It is given via a heparin infusion pump. As we discussed, it is given pre-filter. Not all heparin which is given is removed by the dialyzer. So, some amount of heparin reaches the systemic circulation. This can lead to bleeding. Heparin can also cause thrombocytopenia, heparin-induced thrombocytopenia. Hence, CBC, complete blood count, and APTT, activated partial thromboplastin time, should be monitored. The target APTT is 1.5 to 2 times the baseline. The frequency of monitoring shall be further discussed in the workstations. Same schematic diagram showing the heparin anticoagulation, which is pre-filter. Regional citrate anticoagulation. Regional citrate anticoagulation. The mechanism of anticoagulation: citrate combines with calcium to form calcium citrate complex, and this prevents calcium mediated clotting. Calcium is an important factor which is responsible for the clotting of blood within a dialyzer. By giving citrate before the dialyzer, citrate combines with calcium to form the calcium citrate complex, and this is removed across the dialyzer and it passes into the effluent. Since calcium is removed within the dialyzer, clotting within the dialyzer is prevented. However, since calcium is removed, the return blood will contain low calcium. So we need to infuse calcium post-filter. So citrate is infused pre-filter, calcium is infused post-filter. 4% trisodium citrate and 2.2% ACDA are the common solutions used for citrate anticoagulation. What are the problems associated with regional citrate anticoagulation? Patient can develop metabolic alkalosis, so blood gas monitoring is important. Citrate can accumulate in patients who have liver failure. Many patients in the ICU tend to have multi-organ dysfunction, liver failure. Since citrate is used and it is metabolized by the liver, it can accumulate in liver failure. Hypocalcemia can happen, the mechanism of which we just discussed. So, we should monitor the post-filter ionized calcium to adjust citrate dose. We should also measure the serum ionized calcium and the total calcium to adjust the calcium drip. This is a schematic representation of regional citrate anticoagulation. This shows us citrate which is infused pre-filter, so that within the filter the calcium citrate complex is removed and calcium is lowered so that clotting is prevented in this filter, and the blood which is coming out will have low calcium, and hence we need to infuse calcium so that the patient does not develop hypocalcemia. This is the anticoagulation apparatus in the CRRT machines. This is the Baxter Prismaflex machine. This is the Fresenius Multifiltrate Pro. And this is the heparin pump in these machines. And this is the pump holder. And the heparin is given pre-filter, that is before the filter in heparin anticoagulation. Whereas in regional citrate anticoagulation, we have the citrate infusion pump which will give citrate pre-filter. The calcium infusion pump which will infuse calcium post-filter. In this machine, the pre-blood pump infuses the citrate solution which goes by the name Regiocit in the Prismaflex, and post-filter calcium can be given through the infusion pump, or it can also be given by a separate line to the patient. Finally, the safety alarms in CRRT. We had seen previously the various sensors which are present in the CRRT machine, which analyze various aspects of therapy and give us an idea about the access pressure, the filter pressure. Disconnection gives rise to alarm. Air in the circuit detected by the air detector gives rise to the air in the circuit alarm. And the blood in the effluent is detected by the blood leak detector, which gives the blood leak alarm. Whenever the safety limits of the pressures are crossed, these alarms ring and alert the personnel who are performing CRRT, and appropriate troubleshooting measures should be taken. More on the safety alarms and how to troubleshoot each of the alarms shall be discussed in the workstation. Thank you for your patient listening. If there are any queries, concerns, suggestions or comments regarding this presentation, you can contact us. We welcome you to the Dialysis Technology Update 2024 at AIIMS Nagpur, and we would be glad to clarify any queries or concerns. Happy learning.